Thank you, Dr. Fernandez-Becker. It's a pleasure to be here today to be able to share some of our experience and pediatric endoscopy with you. Is the microphone okay? I have no disclosures. So an overview of the session today and the time we have together this morning, I'd like to first briefly share my background and areas of focus within endoscopy research and practice, and then provide an overview of endoscopy practice in the youngest patients, highlighting a few dimensions of my work and our experience here at Stanford in caring for pediatric endoscopy patients. First, my pathway in endoscopy is a bit unique. Since my medical school days and throughout internal medicine residency and adult GI fellowship, I've engaged in continuity experiences within pediatric GI. And really it was those continuity experiences and experiences during interventional endoscopy fellowship that highlighted the dramatic gap in therapeutic endoscopy between children and adults. And that's what brings me as an adult gastroenterologist and interventional endoscopist to apply some of my skill set to pediatric patients. I now have the unique opportunity to dwell within pediatrics and medicine in the endoscopic environments, and that's some of what I'll share with you today. In my initial time as what I like to call a full lifespan endoscopist, I was surprised. I was surprised that despite the same tools, technical approaches in general, there were more differences than similarities in pediatric and adult endoscopy. I anticipated differences in size to some extent, as well as indications, as well as practice patterns and volume. But the magnitude of these differences and the divergence in approach to endoscopy and safety priorities were really noteworthy and provide rich areas for improvement and optimization of care. So as we launch into the characterization of pediatric endoscopy and our experience, I wanted to share why this is relevant to an adult gastroenterologist. There are some reasons why this information is clearly important for each of adult gastroenterology colleagues to know. First, children are an underserved sector. And data in the pediatric endoscopy, emerging data, including from our center, highlight the need for partnership between adult and pediatric gastroenterologists to really provide optimal care for the youngest and most vulnerable patients. This is a role for adult gastroenterologists in pediatric training and also in supporting some of the interventions for pediatric patients. Finally, children mature into adults, and a lot of these pediatric patients will transition to adult practice, and therefore an understanding of pediatric endoscopy and the pediatric conditions that require endoscopy is important for all adult gastroenterologists. And finally, the latter is really something that I think could impact all of us, and that is it's really gratifying to have an 80-year impact, an 80 life year impact on care when you care for a 2-year-old or a 3-year-old patient, and even support those who care for the youngest patients. So that's something that is worthwhile considering as you listen to the rest of this talk. So now I'll launch into our first study in pediatric endoscopy. So as initial entree into the pediatric endoscopy space, we spearheaded a project to characterize pediatric endoscopy practice patterns. Now, this has been done on a single center basis, but what we needed to do was understand how pediatric endoscopy is practiced on a national and North American level. So we distributed a survey to all the major pediatric endoscopy centers. This is 63 centers in the US, Canada, and Mexico. As a testament to the perceived importance of this topic, we had a very high 83% response rate from each center, and that's based on the number of centers. And 77% of respondents included free text comments. We were very engaged in the survey and noted the importance of the area. So what I'll share with you in the next few slides are some of the data surrounding endoscopic procedures and volumes performed in pediatric patients, and how pediatric therapeutic endoscopy is a bit different in flavor than adult therapeutic endoscopy. So not surprisingly, the vast majority of respondents reported that EGD and colonoscopy were performed at their center. You can see 93% of the centers reported that EGD and colonoscopy were performed. So this is not surprising. Foreign body removal and PEG tube placement are performed at more than 80% of responding institutions. So also these are bread and butter pediatric endoscopic procedures. Now, once we get in, the divergence between adult and pediatric endoscopy practice becomes a little bit more clear as the therapeutic interventions are included. There's still a majority, but a declining majority of respondents who report upper and lower endoscopy with dilation are performed at their center. Still, these are really mainstays of pediatric endoscopy practice, and they're not performed at a subset of institutions. Still, greater than 70% is reasonable. Next, when we get to basic hemostasis interventions, just about half of institutions, slightly over half, perform hemostasis at their center. These are institutions with active inpatient services, and yet hemostasis interventions are not really performed. And it's interesting because indications for hemostasis still arise in the pediatric population, and these include APC, variceal band ligation, sclerotherapy, but they're not performed at high rates at these pediatric institutions. So this was one of our first conundrums. And then when you get to enteroscopy, push and balloon enteroscopy are much less common in the pediatric population, with only 30% of institutions reporting that they offer balloon enteroscopy, and even push enteroscopy only at about half of institutions. Now, when you consider the indications for push enteroscopy in pediatrics, they're quite abundant. Putz-Jaeger syndrome, FAP. There's also a lot of more small bowel bleeding and more small bowel IBD indications with bleeding in the pediatric population relative to the adult population. So this was a bit surprising to us. Now, when moving to procedures, previous to this, we've just been talking about procedures that are not thought to be therapeutic in the adult world. But when moving on to procedures that are uniformly characterized as therapeutic, it's notable that pediatric EUS and ERCP are offered at only a minority of institutions, and those that offer them perform them in very, very low numbers, so 10 to 25. Most institutions are performing fewer than 25 ERCPs for pediatric patients. Now, our adult literature and all prevailing literature suggests that these need to be performed at least greater than 100 to 200 per year to maintain competency for a single endoscopist. And it wasn't even a single, additional data I'm not sharing, it wasn't even a single endoscopist performing the ERCPs at these centers. So endoscopists were performing between 5 and 10, maybe fewer ERCPs annually. So opportunities for improvement are particularly apparent in the management of therapeutic endoscopic procedures. In answering this question, do you believe your institution's current arrangement for performing pediatric therapeutic endoscopy procedures is adequate? The vast majority of responding centers indicated that no, they do not. So there's a recognition that there's a need for improvement, but a lack of a knowledge of the pathway toward improvement. So some of these data, what they suggest is therapeutic endoscopic procedures in pediatrics, they're less common. There are fewer indications. There are fewer children than adults. And traditionally, surgery is performed for more hemostasis and other interventions in children, and it has been, despite the fact that a lot of these conditions are amenable to endoscopic intervention. Training and expertise in these areas is limited, and that underscores the need for complex procedure support. So the definition of therapeutic endoscopy in pediatric patients includes hemostasis. It includes dilation. It includes other things that we wouldn't normally think of as therapeutic endoscopy. Regarding hemostasis, there had been a bit of work on pediatric hemostasis prior to us conducting the survey. There was a prior survey of 29 pediatric centers, smaller than ours, but 80% responded. 19% felt that managing GI bleeding, they felt competent managing GI bleeding. 19% felt that none of the consultants on their service had these skills for managing GI bleeding. So this has an impact on patient care. Thus, once we saw these data, we decided that what we needed to do was figure out how to address it on an institutional level. How can we improve quality of care in this lower practice environment? At Lucile Packard Children's Hospital, we launched an advanced complex endoscopy team. So we have 5 people at our center that are experienced endoscopists, one including myself, who are proficient in complex GI procedures. They're able to perform hemostasis maneuvers, and these individuals rotate on the advanced complex endoscopy team. We call it the ACE team, to provide 24/7 inpatient, outpatient coverage and support for those performing these procedures for the primary attending. So we have some data where we analyze the impact of ACE on hemostasis procedures and quality in the 2 years prior to implementation and in the year following implementation. We found a dramatic improvement. In blue is prior to ACE implementation, green is after ACE implementation. We found a dramatic improvement in latency to endoscopy. Prior to ACE, it's the bleed team or ACE team, there were about 4.3 days from the time of consult for bleeding to performance of the procedure. After ACE implementation, it was 1 day. Again, the durability of hemostasis was much better, with 31% of patients requiring an IR surgical intervention even after endoscopy prior to ACE, and following ACE implementation, about 6%. Now, a subset of pediatric patients will require surgery. Some of these patients are cardiac patients with aortoenteric fistulas, other things. So we'll never get that down to 0, but it's a dramatic improvement. Also, you can see that prior to ACE, the pie chart on the left, hemostasis therapy modalities were pretty limited, and there was no intervention in a subset of patients. Following ACE implementation, hemostasis therapy modalities, multimodal therapy was more common, and there was a broader range of therapy given that people with more expertise were performing the endoscopic procedures. Additionally, the volume of endoscopic procedures went up. So pre-ACE, you see 19.5. The reason for the 0.5 is that it was an average over 2 years prior to ACE implementation to get a better sense of the baseline. Following ACE implementation, 64 procedures were performed, and a dramatic increase in the proportion of those procedures with hemostatic therapy. We attribute this to the attending on call being comfortable calling a complex endoscopy person to help perform the procedure. It's not that the characteristics of the procedures have changed. In additional data, I can show you that the characteristics of the consults have not changed, but our approach to the consults have changed. So this is encouraging. We've presented this at national meetings in pediatric endoscopy, pediatric GI. Several other institutions are working on developing complex endoscopy teams. Ours was the first of its kind within pediatric endoscopy. We're proud of the improvement in care. I just wanted to highlight this because it also represents a partnership opportunity between adult and pediatric gastroenterologists. Not every center is going to have 5 pediatric gastroenterologists who are comfortable performing hemostasis, so sometimes this adult partnership is necessary. In the few minutes that we have remaining, I just wanted to highlight some of our other work within pediatric endoscopy, focused on ERCP. As I'd mentioned and alluded to, ERCP is performed in such low volumes at a lot of the centers performing ERCP that it's important, because this is one of the highest risk endoscopic procedures, for us to identify quality parameters and help improve those quality parameters. The reality is the quality parameters in children are inferior to those in adults right now. And the indications are expanding in pediatrics. There is some bile duct exploration surgery for stone management still going on in pediatrics, and that's something that's pretty important to address because that's something that we don't do in adult patients anymore. So we've evaluated endoscopic ERCP-based interventions, especially fluoroscopy time, and cholangioscopy and other approaches for management of biliary disease in children, and are helping to improve that sector of care. Additionally, within endoscopic ultrasound quality applications, there are several applications you can see here. This is just one example in the video going on the upper right that for hemostasis for gastric varices, EUS-guided approach can be really valuable for pediatric patients, similar to what we do in adult patients with coil placement, ultrasound-guided coil placement to manage these varices. Pediatric patients have a high proportion of these patients go on to transplant, and if we can manage their gastric variceal bleeding in ways other than shunts, it can be really beneficial, particularly with the small anastomoses that our transplant surgeons need to perform for pediatric patients. So here you can see a coil is going into the gastric varix, and in a moment what you'll see is the after picture with the varix decompressed. And on the other side of the screen, we have evaluated landscape of EUS interventions in pediatrics. And those EUS interventions and opportunities for care are improving. It's a little dark, but you can see that the varices have largely collapsed there. And that was just in the time span of the procedure. Finally, in the last minute, endoscopy operations and education within pediatric is another priority. By applying things that we've learned in adult endoscopy, the block systems, organization of endoscopic procedures, and promoting efficiency, that's led to pretty significant improvements in pediatric endoscopy efficiency. And under development is a pediatric endoscopy curriculum. As you can imagine, in low volume of procedures, it's hard to train fellows appropriately. So we're bringing other multimodal therapy, including simulators, virtual reality, and a digital curriculum. Thank you so much for your attention and for the opportunity to talk to you.
Thank you, Dr. Barakat, for that wonderful talk. Our next speaker is Dr. Andres Gottfried. Dr. Gottfried is a gastroenterologist and a physician scientist whose research focus is in neuroimmunology. He is a member of our neurogastroenterology and motility program, where he cares for patients with gastroparesis and other motility disorders. Through his research, Dr. Gottfried aims to apply his background in neuroimmunology and inflammation to advance our understanding of gastroparesis and other functional motility disorders. The title of his talk is What Causes Gastroparesis and Why is it Increasing?
Good morning, everyone, and thank you for the organizers for this amazing opportunity. So what I'd like to achieve today is review the causes of gastroparesis. This is still a challenge and an ongoing debate, and have a brief discussion on why gastroparesis is increasing. And I have no disclosures for this talk. So briefly, we need to define first gastroparesis. I know we heard from Dr. Wen yesterday, but I just want to quickly review. Gastroparesis is defined as abnormal or delayed gastric emptying in the absence of a mechanical obstruction and associated with chronic symptoms of nausea, vomiting, bloating, early satiety, abdominal pain, or weight loss. Now, who gets gastroparesis? This comes from a large survey showing that the median age of patients getting diagnosed with gastroparesis is around 40 years old, but you can see the age range is very large. And we're still not doing a great job at diagnosis. It usually takes patients at least 5 years for their diagnosis to be made by the time from the start of their symptom onset. The other notable data on this table is that in the U.S. and other Western countries, it's prominently a disease that affects women. This one says 92%, but it's usually 1 in 4 in other studies. And also, it's mostly race, white females who get this disease for the most part. What are the accepted causes or associations with gastroparesis? Back in the 90s and early 2000s, this was the accepted distribution. The majority of patients we know are idiopathic, meaning we don't know the cause of their gastroparesis. And the other big sector is diabetes. And then that's followed by post-surgical causes, and then other more rare conditions like neurodegenerative disease, autoimmune disease, drug-induced, and others. A more recent study published just last year showed from a very large survey of patients that the amount of diabetic gastroparesis is significantly increasing. I don't know why idiopathic turned out to be so small in this pie chart. In my personal practice, I still see mostly idiopathic patients. But it's certainly something to note. Surgical cases also increased a little bit, as well as drug-induced. So the way we diagnose gastroparesis is basically by measuring stomach emptying. And as Dr. Wen discussed yesterday, the gold standard is gastric scintigraphy. It's a 4-hour test with a solid meal. And the cutoffs is 2 hours, you got to have more than 60% retention, or at 4 hours, more than 10% retention. Now, we have other tools now to measure gastric emptying, and these are clinically approved. We have the wireless capsule motility, which allows us to measure transit throughout the entire gut. For the stomach, the cutoff is 5 hours. But many of us feel this is not a very physiologic test because the capsule is a non-degradable, instruments, and so what this test is mainly measuring is that migrating motor complex, which sweeps and empties the stomach periodically. The other test we have available now is a breath test. It's a carbon-13 spirulina breath test. Basically, patients are fasted, they eat a meal that's labeled with carbon-13, and then they exhale the carbon, and we measure it in the breath. And it has a very nice correlation with scintigraphy. And so this is a non-invasive way to measure gastric emptying now, and it's been very popular for research. So to understand the causes, the mechanisms of gastroparesis, it's worthwhile reviewing a few basic aspects of normal stomach function. As you know, the stomach is divided into compartments from the proximal to the distal part. Proximally, you have the fundus, then the body, then the antrum, and then the pylorus, which connects to the duodenum. The fundus is considered mostly a reservoir for the stomach. It's considered to regulate liquid emptying. And the big part it plays when we have a meal is to accommodate and relax and allow the meal to sit there. And this is known to be mediated by inhibitory neurons of the enteric nervous system. Next, we have the body, which is where we know is the main region where the pacemaker region is located. And this is where interstitial cells like Cajal initiates the slow wave myoelectric activity, which regulates the motility of the stomach and sets that frequency of 3 cycles per minute, which controls stomach motility. Then we have the antrum, which is the more muscular part of the stomach, and this is the part of the stomach where grinding and mixing of food takes place to make chyme. And this is very important because the pylorus is a muscular sphincter, which allows only chyme of a certain millimeter size to empty into the intestine. And so after a meal, the pylorus is contracted so that this grinding activity takes place. And then finally, there's a very important coordination between the duodenum and the antrum. I think about it kind of like, when we talk about defecatory disorders and dysenergia. So these two segments of the gut are highly coordinated through neuronal reflexes and endocrine reflexes. And it's a mechanism in place so that the rate of emptying is regulated by the intestine. And all of these need to be working properly. So when we get into the mechanisms of what we know that causes gastroparesis, we can see that actually there's a lot of different aspects that can lead to stomach dysfunction. And so I created this table which shows the first column, the abnormality. So we can see that there's abnormalities in the nervous system, in specific mechanisms of certain segments of the stomach. And I've made a second column showing the location. And I'm going to briefly discuss all of these. And you can see in the discussion, what I'll do is we'll go into what the dominant symptoms are when patients present and you're getting your history. What are the clues that could tell you maybe where these abnormalities are happening? What are the known reported or presumed causes for these dysfunctions? And then what are the diagnostic tests that we can use to sort this out? So when we think about the nervous system, there's the stomach, like the rest of the gut, has an intrinsic and an extrinsic innervation. In the case of the stomach, the vagus nerve is the major extrinsic player. And we know, sorry, I'm figuring out the buttons again. So when you have vagal dysfunction, the dominant symptoms are nausea and vomiting, and also you can get the physiology of a gastric outlet obstruction because it's been well reported from the old literature when we treated peptic ulcer disease with vagotomies that patients would end up with a pylorospasm, and you'd have to have a pyloroplasty to treat that. So we know that vagus damage causes pylorospasm, and so you get that functional outlet obstruction physiology. The known or presumed causes for vagus dysfunction include post-surgical injury, diabetes, autoimmune disorders, and possibly neurodegenerative disorders as well. And the way we can diagnose this is obviously stomach emptying, but to assess vagal function, a lot of us do autonomic testing, which is mostly based on heart rate variability, and that gives you a sense of autonomic dysfunction in general. But a specific test that can be done is the postprandial pancreatic polypeptide test. This is not done very regularly. I don't see it reported very often, but it's a very specific test. It measures how well motor vagal innervation is working in the foregut. So talking about intrinsic neuropathy, so now we're dealing with the enteric nervous system. The dominant symptoms can be any of the above that were mentioned. Typically, we think about diabetes and/or inflammatory causes that affect the enteric nervous system neurons. And the way to diagnose this is usually through full thickness biopsies and muscularis tissue histology, which is usually more in the research realm and not in clinical practice. So moving forward, when we think about impaired accommodation in the fundus, if you take the stomach and do an analogy with the heart, impaired accommodation would be like diastolic dysfunction. So the stomach has a hard time relaxing and accommodating the food. So the main symptom is going to be fullness and early satiety. Just in the interest of time, I'm going to let you look at the table for the causes. But the way we diagnose impaired accommodation is through the barostats. We can also do this by MRI. And an indirect way of measuring accommodation is by a water load test. The next is dysrhythmias of the stomach. So you can get bradygastria, tachygastria, or a disorganized rhythm. This is felt to be occurring in the interstitial cells of Cajal and the pacemaker region of the stomach. It's thought that it's been shown that diabetic oxidative damage can affect these ICC cells. You can also get this from intrinsic neuropathy. And the way to diagnose this is through electrogastrography, which in the traditional sense was a 3-electrode test. But we are seeing a resurgence and interest in this field with very high density array electrodes, which are quite amazing, and that's something to look out for in the coming years. Lastly, there's hypomotility, which is occurring in the antrum, and this would be the systolic dysfunction where the muscle of the stomach is just not working very well. And this can be diagnosed by the barostats or by manometry, anthromanometry. And then finally, you can get sphincter spasm or pyloric dysfunction. And the way to diagnose this would be through endoflip and/or manometry. For endoflip, we're still working on getting, baseline normal functional ranges, normative data, but it can be useful when you're doing interventions to the pylorus. You can get endoflip data before and after, which gives you a sense of whether you've relaxed that muscle or not. And then finally, discoordination between the antrum and the duodenum. This can also be diagnosed by intraduodenal manometry. So in summary, gastroparesis is a multifactorial disease, as I reviewed with you. And I just want to spend the last 2 minutes of my talk talking about the trend, this very concerning trend. These two papers show that from 95 to 2004, and then from 2006 to 2013, there's been this sharp rise in gastroparesis, hospitalizations, and emergency room visits. And this is in contrast to other common GI problems like ulcers or gastritis or GERD. And this is not just adults. In pediatrics, we're seeing the same trend. And this is driven definitely not by a rise in the unique patients, not just repeat patients that are getting sicker. So why are we seeing an increase in gastroparesis? For one, we know there's no cure. This is just the harsh reality for us right now. And this is a chronic disorder. So as patients get diagnosed, we're just accruing numbers without really curing them. The second is in the 90s and 2000s, we saw a huge rise in diabetes. And I think that reflects that increase in diabetic gastroparesis that I mentioned. The next is increased awareness. With online forums and bigger communities, more patients are aware of this, more doctors are aware of this diagnosis. And so I think more patients are getting diagnosed than they used to be. Finally, there was also a big rise in hiatal hernia and reflux surgeries. And so post-surgical gastroparesis from specifically large hiatal hernias it's a 40% rate of gastroparesis after those surgeries. So that could be another contributor. And then, as discussed yesterday by Dr. Yo, we have this huge wave of anti-obesity/diabetes medicines, which directly cause drug-induced gastroparesis, specifically the GLP-1 receptor agonists. And you can see this chart showing the number of prescriptions is just skyrocketing. So we can expect to see more of this. And in my own practice, diabetics that were doing fine with their mild gastroparesis now are presenting to my office with very severe symptoms because they're on these meds. And so, in summary, gastroparesis is multifactorial syndrome with many etiologies. Unfortunately, our current testing paradigms do not really give us information of these causes. We're basically left with a clinical syndrome of symptoms and delayed stomach emptying. And in terms of the rise of gastroparesis, it is on the rise. The true incidence is still unknown. The prevalence, which is estimated to be 1.8%, we don't know if it's truly increasing or not yet. But certainly as diabetes and obesity rise, we're likely to see more gastroparesis from primary complications or therapeutic procedures and treatments. And with that, thank you very much, and we'll see you soon.
Okay, our next speaker is Dr. Laren Becker. Dr. Becker is an assistant professor in the Division of Gastroenterology and Hepatology at Stanford and has a joint appointment at the Palo Alto VA. He received his MD, PhD at Albert Einstein College of Medicine and did his residency in Boston at Beth Israel Deaconess Medical Center, as well as his GI fellowship. His lab is devoted to studying how neuroimmune interactions in the enteric nervous system affect gut motility in health and in disease, with a focus on aging and neurodegenerative disorders.
Sure. Can you hear me? Yeah. Sorry, I wasn't well prepared, and I have to run back and forth because I'm still in endoscopy, so that's why I was a little late. Anyway, this is an interesting topic. It's I think, increasingly gaining traction at some of our conferences, and I'd say that there is a lot of interest. NIDDK just came out, is about to initiate a funding opportunity for gut-brain a study on Parkinson's disease. So I think it's going to be a field that is going to be appreciated more. Anyway, it's also a very broad topic, and there's a lot of neurodegenerative disease alone is a variety of diseases. But I will do my best to do this in about a 15-minute talk. Anyway, so the outline will be: can neurodegenerative disease affect the gut? Can the gut affect progression of neurodegenerative disease in the brain? And finally, where our role as gastroenterologists may fit in this whole management scheme. So we'll start with this question: can neurodegenerative disease involve the gut? And I think increasingly we could say yes to this. So let's back up and first kind of discuss the pathogenesis of neurodegenerative disease. First of all, neurodegenerative disease, as I mentioned, is a broad term. It includes multiple diseases, including Parkinson's, Alzheimer's, ALS, Huntington's, and it's caused by several common pathologic processes. This includes disordered protein homeostasis, in which you see aggregates of proteins. This is, in many ways, the hallmark of many of these diseases. In the case of Alzheimer's, it's amyloid beta deposits. In the case of Parkinson's disease, this is alpha-synuclein. These accumulate to some extent due to loss of lysosomal function, inability to clear these proteins. But the other common processes for these diseases are DNA damage, epigenetic changes, and definitely this immune dysregulation. So the question, of course, is if it occurs in the brain, can it occur outside of the brain? And that's increasingly becoming clear that yes, it can occur outside the brain, including the gut. This is likely the reason why GI symptoms are very common in the disorders like Parkinson's disease and these other ones. Parkinson's has definitely been the disease that's been studied the most for its involvement with GI disorders. And there are several symptoms that are quite common in these patients. 60 to 80% of patients have GI symptoms, and these include dysphagia, drooling, gastroparesis, and constipation. There's significant prevalence of delayed gastric emptying. Now, granted, a lot of these patients are asymptomatic, but if you test them, it's found in up to 70 to 100% of patients have some degree of slowing of their stomach. And in terms of the constipation, when you do studies involving SITS marker studies, smart pill, anal rectal manometry, defecographies, when you evaluate all the possible causes, it's the cause of constipation is combined, both delayed slow transit and dyssynergia in the majority of these patients. Constipation tends to be the most prominent of the GI symptoms. Our group recently did a study that's in revision looking at high-res anal rectal manometry, and using the London classification, we found that certain findings are quite common in these patients, including abnormal expulsion with dyssynergia, rectal hyposensitivity. Interestingly, there was one anal hypocontractility seemed more prominent in female Parkinson's patients than males. So what's notable with Parkinson's disease is that these non-motor symptoms, sleep disturbances, but also GI dysfunction, appear to occur way before you start having any of the motor symptoms, decades before. And this has led to this hypothesis, originally proposed by Brack in 2003, that the disease originates in the body first, like a peripheral body first model. And so the idea is that in early stages, it's in the autonomic and olfactory, and you'll have more of these these non-motor symptoms. And then as the disease progresses into the basal ganglia, you start having the motor symptoms, and then it further progresses into the cerebral cortex, and then you have dementia. The problem, of course, with a lot of these neurodegenerative disorders is that they're first difficult to make diagnoses. It's not very easy to take brain biopsies. Plus, by the time you have these later symptoms, either the motor symptoms or the dementia, the disease is often well advanced, and so therapies are limited at that point. Importantly, there is evidence that Parkinson's occurs in the gut. That protein that I mentioned, alpha-synuclein, has been found in Parkinson's patients. Here we see the signal detected in the gut tissue. It's also somewhat seen in IBD patients, which I'll get back to you, and less not seen in controls. In animal studies, models, they've found that if you inject or overexpress alpha-synuclein, you could cause alterations in GI motility, which fits that the alpha-synuclein may directly be causing the gut dysfunction. And in addition, there appears to be some degree of immune dysregulation with alpha-synuclein. We recently showed that when macrophages in the gut clear the alpha-synuclein, it changes their inflammatory phenotype. And this paper also showed that after injection of the alpha-syn, you have increased inflammation in the gut. There's also evidence that Alzheimer's disease may involve the gut. Here's a it's been amyloid beta, which is the protein that you see in Alzheimer's disease, has been detected in gut tissue. Here we see red signal for an Alzheimer's patient, and it's not seen with the gut. This has also been seen with animal models for Alzheimer's disease. And there's also experiments where a paper that injected amyloid beta and found that this resulted in gut dysmotility and cognitive decline. So the next question is, can the gut affect progression of a neurodegenerative disease in the brain? And there's emerging evidence, unfortunately, that yes, the answer is yes, and it could it affects it at multiple steps. One being initiation of the disease, second propagation, and third amplification. So I'll tackle each of these, starting with disease initiation. This is again mainly studied, most studied in the case of Parkinson's disease, but it also may involve some of these other neurodegenerative diseases. And there's some evidence that enteric infections, including norovirus, can predispose you to developing Parkinson's disease. Additionally, various pesticides have been linked to Parkinson's disease, including paraquat and retinone, and is one of the reasons why you see higher incidence, it's believed, in the Central Valley of California. And in animal models, administration of these same pesticides seems to cause increasing enteric alpha-synuclein aggregation that then propagates to the brain. And then finally, a little disturbing, this kind of comes out of the HBO show, recent HBO show, these bacteria. So these amyloid proteins that you see in the aggregate are not just typical protein aggregates. It seems like it's believed that they behave like prion disease. So meaning that the aggregate seeds another, one cell seeds another cell with these protein aggregates, and then it develops, it's passed along that way. And there's some evidence that certain proteins made by gut bacteria, including this one called curly, can actually start this whole seeding process. So propagation has been, the vagal nerve has been implicated in the propagation of this disease. Again, this is the whole concept of nerve-to-nerve transmission through a prion-like process. And vagotomized patients seem to be at decreased risk of developing Parkinson's disease. And in these animal models, vagotomy prevents the propagation of alpha-syn to the brain. Finally, getting to amplification of the disease, this in many ways is is very similar to the whole gut-brain axis. It kind of covers the same concepts. One of which is that gut inflammation can promote neurodegeneration. So the idea is that factors released in the inflamed gut can then modulate the immune cells in the brain and then promote the disease. And this is one of the reasons it is believed that you see higher incidences of Parkinson's disease in patients with IBD. Moreover, when you treat in patients treated with anti-TNF, this risk seems to be reduced. In animal studies, they've done DSS colitis and enteric infections, and they showed that both these promoted progression of the of neurodegenerative disease, either Parkinson's or Alzheimer's, in the brain. Gut dysbiosis has also been implicated in neurodegenerative diseases, and there's a variety. It's not all consistent between the diseases, but alterations in the gut microbiome have been detected in many of these diseases. And some of this seems to be related to the metabolic byproducts of these microbial dysbiosis with changes in bioavailability of metabolites. This is, in at least an animal model of ALS, has been demonstrated. So, in summary, there appears to be emerging evidence that neurodegenerative disease does in fact involve the gut and accounts for the high prevalence of GI disorders in this patient population. at least a subset of this neurodegenerative disease appears to propagate from the gut to the brain and can be triggered by various events, including enteric infections, pesticides, and gut bacteria. And then finally, gut factors, including inflammation in the gut byproducts released by the gut microbiota, may promote neurodegenerative disease by modulating CNS inflammation. So where is the role of the gastroenterologist? So first off, I think it's not going to, hopefully in the reasonable near future, there'll be a point where we may be able to start detecting these neurodegenerative diseases at early stages, possibly at the time of first screening colonoscopy in patients who are having constipation. We take biopsies and look for signs of Parkinson's disease. There may be additional motility tests that we could then do to help confirm this possibility. If these high-risk patients are then identified, we could then look at their microbiota and see if they have a dysbiotic phenotype that puts them at increased risk, and then recommend, as Sean will get to, various therapies like FMT or next generation of probiotics. And then finally, make recommendations about their diet. In those at high risk, they definitely should be avoiding pesticides, but we could also, hopefully down the line, recommend diets that promote a healthy microbiota so they reduce their risk from that standpoint. And that is it for me.
All right, moving right along. Our next speaker is Dr. Sean Spencer. Dr. Spencer is a gastroenterologist and physician scientist with an interest in the gut microbiome and mucosal immunology. He obtained his medical degree at the University of Pennsylvania and his PhD studying nutritional immunology at the NIH, and later went to Boston for residency at the Massachusetts General Hospital. And we were lucky that he came to Stanford for GI training. His career goal is to study the mechanisms by which dietary intake influences our microbiome and immune system to better understand and treat gastrointestinal disease. The title of his talk is How to Modulate the Microbiome with Food to Treat GI Disease. Thank you.
Thank you for that introduction and for the opportunity to speak today. Excited to talk to you about food and the microbiome in the context of GI disease. So, as many of us know, we harbor trillions of microbes within us. And the important thing to understand is not only do they outnumber the cells in our body, but the genetic content that they have within them is about 100 times greater than our genetic potential. And what are they doing with all of these genes? And as I'll discuss today, a really important role that the microbiome plays is to digest fiber and make beneficial metabolites that promote our health and prevent GI disease. The human genome contains 17 genes to degrade carbohydrates, mostly simple carbohydrates, in the small intestine. However, when we eat fiber-containing foods, these are complex carbohydrates that we are not capable to break down ourselves. These go to the colon, in which the largest density of our microbes live. They take these complex carbohydrates and they degrade them into beneficial microbial metabolites that circulate throughout our body. An important thing is that the microbiome contains nearly 100,000 genes to degrade fiber and seems to be its main role in terms of fermentation in the colon is to process these plant-based fibers. And then I also want to kind of raise the term prebiotic. This is another term for fiber. This is a substance that promotes the growth of beneficial bacteria. It's bacteria that eat fiber, then benefit and grow as a result. The main issue is that the standard American diet lacks fiber, and this starves our microbiome, and this, we think, causes issues. When we lack these complex plant-based fibers, we lose diversity of our microbiome. More importantly, we lose these microbial metabolites that promote health and homeostasis. And we know that even aside from diet, inflammation and GI disease can drive the same process of loss of microbiome diversity and loss of these metabolites. This has been well demonstrated in IBD, after antibiotic use, and in chronic liver disease. And so I then wanted to talk about the term microbiome dysbiosis. This is a term you may have heard. And this really is a situation in which the microbiome configuration, you have an excess of quote-unquote bad bugs, for lack of a better term, and really a decrease in the good bugs that degrade plant fiber and have beneficial properties. And this is really the microbiome that seems to be present in most GI disease processes. This results in a lack of key beneficial functions of the good bugs, and then also you can witness increased harmful effects of the bad bugs. And what do we do about this? So there are some main therapeutic approaches. One is to kill the bad bugs. That's unfortunately the mainstay of our current GI practice. The downside of this is there's really no way to target the bad bugs specifically, and this ends up targeting all bugs within our GI tract and doesn't necessarily address the underlying cause or driver of a dysbiosis. Emerging therapies are to give the good bugs through microbial therapeutics. And we're seeing a rise in these trials and some promising signatures from these clinical trials. This mainly occurs via FMT is the main current option, although there are some microbial therapeutics coming online, hopefully in the near future. The other point I wanted to stress here is that current probiotics are microbial therapeutics, but they are not microbiome-derived therapeutics, the vast majority of them. These are non-native to the microbiome, and increasing evidence suggests that they do not reverse dysbiosis. They may even reinforce a dysbiosis if present. So just want to be very clear on that point. Thirdly, which I'll talk mainly about today, is to support the good bugs through fiber and prebiotics. And currently, we don't have any high-quality, well-studied prebiotic fibers. So really the best way to do this is through fiber-containing whole foods. So really, I think what's clear is our patients should eat fiber. And I wanted to run through a quick, really striking example of this, not in a GI disease, but in cancer immunotherapy. And there's really solid evidence now that fiber augments cancer immunotherapy, while probiotics inhibit it. And this was a study that came out recently out of MD Anderson. And it found that over-the-counter probiotic supplement use was linked to a 70% lower chance of response to immunotherapy, and this was anti-PD-1 in the context of melanoma. Strikingly, 42% of the patients were consuming probiotics. Probiotics were linked to lower gut microbiome diversity and with a poor response, as I discussed. Very interesting of the study, patients eating high-fiber diets were 5 times as likely to respond to immunotherapy treatment. And here are the Kaplan-Meier survival curves. And you can see what's quite striking here is that fiber consumption in the absence of probiotics was most protective, whereas you'll also see that fiber consumption in the presence of probiotics was not protective. This really suggests that our patients should be consuming fiber and not probiotics. And this is specifically in the context of checkpoint immune therapy for melanoma. I think we're all familiar with the problem. Our patients don't necessarily always enjoy eating fiber, and this is largely due to GI symptoms. And if you consume fiber in the setting of a microbial dysbiosis, it does lead to disordered fermentation and GI symptoms. And I hope to present some approaches to this in patients that can work around this a little bit. So I think most well accepted in terms of GI symptoms of barrier to healthy eating, specifically in our patients with irritable bowel syndrome, is the low FODMAP diet. It's currently the most evidence-based intervention in IBS. And what are FODMAPs? It's an acronym that stands for fermental oligosaccharides, disaccharides, monosaccharides, and polyols. And essentially these fermentable carbohydrates are all the same things that I told you that our bugs like. Although the main point here is that disaccharides and monosaccharides tend to be simple carbohydrates, whereas the oligosaccharides, there are some that are very well tolerated. And the point as well that I wanted to make is that the low FODMAP diet consists of 3 phases. the restriction phase, lasting about a month. And then importantly, it's followed by reintroduction and personalization, but unfortunately, this often gets left by the wayside in our patients. An important point is that the mechanism of FODMAP intolerance is mediated by poor absorption, but it's also mediated by by inappropriate microbial fermentation. So this is a fermentation that's thought to be dysbiosis mediated and one that causes symptoms. And I think in practice, what this often results in is a bit of a downward spiral that reinforces a dysbiosis. And this starts with environmental factors leading to the dysbiosis. In our patients, this is usually infection, antibiotic use, inflammatory or other GI disease. This results in symptoms with fiber intake, then resulting in patients adopting a low FODMAP and gluten-free diet, often permanently, not through a phased approach, and really, in practice, results in a low-fiber diet consumption, which further reinforces microbiome diversity and a worsening dysbiosis. Patients in the absence of GI symptoms have a diverse food choices. However, when they adopt a low FODMAP gluten-free diet, in the absence of working with a dietitian or a licensed colleague, really have a highly restricted eating pattern that can be borderline dysfunctional, as increasing evidence is showing. And here I just wanted to highlight a patient who came out with a cookbook that is FODMAP and gluten-free, but includes a lot of plants and fiber. And in the introduction to this, I think it's really telling of what our patients are going through. She said, "My fierce love of food is paralleled only by my body's fierce rejection of practically everything I eat." And sometimes patients really feel like this, and it causes a lot of anxiety that reinforces the disorder of the gut-brain interface. And I think what she goes on to explain in her book is that by discovering a diversity of plant fibers, she was able to help reduce her symptoms with food consumption. And what does this mean practically? I wanted to say some pearls for the GI patients that are FODMAP avoidant. As I discussed, although FODMAP is intended for short-term use, most patients become permanently FODMAP avoidant, and we know that this leads to restrictive eating patterns in a lot of these patients. I wanted to stress that not all grains have FODMAPs, not all grains have gluten. All wheats have gluten, but not all grains are wheat. There are plenty of low FODMAP, gluten-free, and most importantly, delicious grains that don't have FODMAPs or gluten. Teff, millet, buckwheat, oats, rice, and quinoa. And there are actually a few more. If you go on the Monash website, they actually have a really nice list of low FODMAP gluten-free grains. As well, things that support our microbiome and are now evidence-based, spices, nuts, seeds, are great and generally can be well tolerated in these patients. Also, patients enjoy additive food advice. I think we're too used to telling patients what not to eat, and we should spend more time on telling patients what they can eat rather than restrictive advice. And then I briefly wanted to touch on gluten. I think there were some pivotal studies that came out in the last year which demonstrate that non-celiac gluten intolerance is not a clinical entity. These were two high-quality randomized control trials. One is in IBS patients given a low FODMAP diet, and they were actually given a placebo-controlled, either placebo or a high-dose gluten pill, and there was no difference in symptomatology. There was another in IBS patients. It was a randomized placebo-controlled crossover trial. They gave patients either, they administered them FODMAPs, gluten or placebo, and FODMAP was the only treatment with increased symptoms. This really suggests that wheat beta-fructans are the culprit. And what this means is that it's not a non-celiac gluten intolerance, it's actually a non-celiac wheat intolerance. And this is likely microbiome mediated rather than immune mediated. Again, the Monash website on FODMAPs has really good advice on this. There are low fructan wheats. These are ancient wheats. So these do still contain gluten, but again, gluten's not the problem. It's really the fructans. And these are low fructan wheats. Spelt, kamut, einkorn. As well, traditional sourdough fermentation actually ferments a lot of the beta fructans into much more tolerable forms. And so if you take an ancient grain or an ancient wheat and you submit it to traditional sourdough fermentation, there have been a lot of studies that these are actually very well tolerated in settings of IBS. And then what the proposed model is that by reintroducing fiber, you can then promote a healthy microbiome. The goal is to empower patients to make food choices that are delicious, first of all, healthy, microbiome friendly, culturally appropriate, sustainable, and without fear of GI symptoms. And then in the last part, I just wanted to raise an issue, is that some patients may have permanently lost fiber-degrading bacteria. And this seems to be the case in some IBD patients. We know that patients with IBD report fiber intolerance. There have been clinical trials in purified prebiotic fibers that show a bimodal response. Some patients increase beneficial bacteria and reduce inflammation, whereas some show increased inflammation and are really fiber intolerant. There's a recent randomized control trial that I think really previews a future approach. It's an FMT then paired with an anti-inflammatory diet that has fiber in it. And when they compared the FMT with the dietary intervention alone, it was superior to standard medical therapy. So these were patients, the only therapy that they were getting for their mild ulcerative colitis was FMT and diet, no other medical therapy, and it was superior to standard medical therapy. So I think this may be, at least in some patients, particularly with mild disease, may be an approach we'll see in the future. So I think the future of nutrition, I think we need to be better at assessing the microbiome for fiber degrading capacity. I think what I'm really hopeful for is in the future, if we detect that the microbiomes of our patients lack fiber degrading capacity, we can give it back in the form of an FNT or a microbial therapeutic. And then really the third step is to support fiber degrading bacteria with fiber rich foods, or hopefully in the future we'll have prebiotic supplements. So in essence, we'll use a symbiotic approach where we will give next generation probiotics with fiber degrading capacity and then give the fiber that they are matched to produce beneficial microbiome metabolites from. So I really think this is where we'll be in 10 to 15 years. And with that, just want to say thank you for listening.
Thank you, Dr. Spencer. That was a great talk. The next speaker is Dr. Sundeep Singh. Dr. Singh is a clinical associate professor who obtained his medical degree at the University of Michigan School of Medicine, internship and residency at University of Texas Southwestern, and GI training here at Stanford. His clinical interests include IBD and general GI, and he's a gifted teacher. He is currently based at our Emeryville and Pleasantville locations, and the title of his talk is Everything You Never Wanted to Know About Hemorrhoids.
Good morning. Thank you for this opportunity to talk to you about hemorrhoids. This is not exciting. There's not a lot of references you'll see, but this is a very common topic. And unfortunately, there's a huge gap in medical education for benign anorectal disorders. And so, coming out of gastroenterology training, I can admit I knew very little about this topic, but over the course of my practice, I had to learn a lot about it because it is one of the top 3 reasons the patient comes to see a gastroenterologist. So I'm going to cover the anatomy, the physiology, the risk factors, the symptoms, and the treatment. And unfortunately, our knowledge is so limited that a lot of my references go back to antiquity. So the basic anatomy is that the pink is all muscle, yellow is fat, and then you have the hemorrhoidal cushions in a normal patient, which then hypertrophy, and you can see on this right side it's becoming a little bit thicker, and then it becomes even larger and develops into a grape-like structure from the internal hemorrhoidal cushions. Now that's separate from the external hemorrhoids, which really develop on the outside, but you note that most of the blood is coming from the internal hemorrhoids to the external hemorrhoids. Now often when patients come in with symptoms, I'm going to focus on talking about the internal hemorrhoids because that's where, for us as gastroenterologists, we can provide the greatest benefit, because often the issues with external are more hygienic because they have residual skin tags, and it makes it difficult to clean themselves effectively. Now, in terms of evaluating this, the most effective way continues to be anoscopy, which unfortunately, since the advent of colonoscopy, is kind of a dying art. So there's two forms of anoscopes that you can find, and one is just it's a circular device. One of my patients yesterday described it kind of like having a pap smear of your rectum, but it's uniform across all three sides. You insert it into the rectum, and then you can really appreciate the last few centimeters of the anal canal and rectum. The alternative is a slotted anoscope where there's an angle. Now, that angle is nice because there's 3 hemorrhoidal cushions, and so if the patient's laying in the left lateral positions, you can accentuate and really nicely visualize that specific side. And so I end up having to evaluate the patient 3 different times by inserting it so that I can effectively evaluate 360 degrees effectively. If you use just a traditional anoscope, which you'll often find in primary care clinics, you're not able to appreciate the sides as much. And the analogy I would use is kind of like when we're doing a colonoscopy, there's all these new devices to help with mucosal exposure, such as endocuff. And if you do a standard colonoscopy and you're just withdrawing, looking straight forward, you can see the sides, but you're not doing a great job. But unfortunately, with an anoscope, unlike with a colonoscopy where you can angulate to the sides, it's analogous to something like endocuff where you can then turn to the sides. So what I find fascinating is how little is understood about why they develop and who they develop in. So it's not really well understood. We think that it has to do with enlargement or displacement of the anal cushions. And that sliding then creates a snowball effect where you have dilation, distortion of the hemorrhoidal plexus, hyperperfusion, and there's some evidence of inflammation there. Now, the risk factors, most of us are familiar with constipation, prolonged straining, but there's very little data to actually guide that. The only risk factor we're really confident in is pregnancy as a result of the pushing process during childbirth, but otherwise aging and obesity have also been shown in small series. In terms of this common reasons the patient will come see you. So this will sound odd, but patients often come and see me, and when they say, I'm coming to see you for hemorrhoids, they just mean that something's going on in their anal area. So that includes a broader differential. It can be anything from an anal fissure, which is a small cut typically on the posterior side. It can be functional disorders of the pelvis. It can be condylomas, squamous cell carcinoma, any number of things. And this is where it really behooves you to actually look and do an anoscopy to kind of directly evaluate it. Unfortunately, often I'm seeing patients who have seen multiple providers in the past and no one's actually looked. But then, very quickly between a rectal exam and an anoscopy, you can get your diagnosis. So the most common one I see is painless rectal bleeding or the sensation of prolapsing rectal tissue during defecation. Itching is sometimes common, and this really gets into, if you remember from the picture, the hemorrhoids are propping open the anal canal, and that allows stool to seep out and inability to kind of clean that area. And then the sensation of fullness because there is extra tissue in there. And unfortunately, a lot of patients will say, listen, I have constipation because I have hemorrhoids, and they have that association backwards. And I'm like, no, the hemorrhoids are not like hard, rigid structures. You should be able to pass the stool, but it's very likely that because of your having constipation and straining and so forth, that you've developed these hemorrhoids. And if we don't address your constipation first, the hemorrhoids are just going to be a chronic issue. And that's another common mistake I see is that people might even have their hemorrhoids treated. They might even have hemorrhoid surgery, but they haven't changed their underlying bowel habits. And so they have the issue come back several years later. The external hemorrhoids are characterized typically on a chronic basis by just residual skin tissue. Sometimes people will come to me and they'll be referred urgently because no one's evaluated the area and they say, I have a hard lump there and I'm excruciating pain. And to me, that tells me the person probably has a thrombosed external hemorrhoid, which from my perspective as a gastroenterologist, there's very little I can do except suggest soaking their bottom in a sitz bath to decrease the anal sphincter spasm and to help break down the blood clot that is developed within the hemorrhoid. In terms of grading the hemorrhoids, this is really helpful in terms of driving your treatment. So grade 1 is the tissue doesn't prolapse. 2 is prolapsing with straining. 3 is prolapsing and requires manual reduction. And 4 is non-reducible. Now, what I find fascinating is the symptoms and the grading don't often correlate. So I had a patient yesterday, she says, I'm bleeding every time I have a bowel movement. My colleague had done a colonoscopy, and now the patient wants this addressed, but she had grade 1 hemorrhoids. And other times, I'll do a colonoscopy and someone has massive grade 3 hemorrhoids, and I ask the patient, are you having any issues? And they're like, no, I'm fine. And so that lack of correlation is interesting. So I'm going to focus on non-surgical treatment since I'm not a surgeon. And, the strongest body of data is based on fiber and then in-office procedures. But fiber has been shown to improve symptoms in about 50% of people, and there's a number of studies on this. So, but we just finished talking about why it's challenging to get people to take fiber, and so that's the same challenge you'll deal with in this situation. Plate tectonics, which is something I actually learned about in preparation for this talk, has some scattered studies. I've never suggested it, but it's an option you can look at. And then there's several office-based procedures or that can be done during endoscopy. So sclerotherapy and cryotherapy I'm not going to talk about because cryotherapy has a lot of residual pain, is essentially dead. Sclerotherapy, I think, still gets done, but is less effective. But band ligation and infrared coagulation are really kind of the standard first step therapies in 2023. And there's meta-analyses that look at which one's better, but across all the studies, they seem to have a success rate somewhere between high 60 percentiles to 95%. And depending on the study you look at, one will be better than the other. And ultimately, I think it's what you gain familiarity with, what you're interested in utilizing in your practice. For hemorrhoid band ligation, this developed out of an older surgical technique where they would, under an examination under anesthesia, use forceps to pull the hemorrhoids out and place rubber band over it. This induces tissue necrosis, and eventually the hemorrhoid falls off. And the risk of complication goes up with the more hemorrhoids you treat in one session. Over time, a variety of companies have come out with much simpler devices that you can use in your clinic or at the time of doing colonoscopy, but they all seem to have similar effectiveness, and it's a question of which one you get trained in. Infrared coagulation, in contrast, uses energy to kind of induce scarring in the submucosal layer. And there's also a variety of devices out there that are available, and each one, the marketing team will have their pros and cons. What I found interesting is that we often tell people don't spend a prolonged period of time on the toilet, don't strain, because gravity is essentially sucking your rectum out. But there's actually no studies to kind of prove that point. There hasn't been any studies on hydration or laxatives. And what I find fascinating in preparation for this talk, there was an Irish monk who famously is the saint of hemorrhoids and spent days praying on a stone for relief of his hemorrhoids. And the hemorrhoids left a permanent indentation in the rock. And apparently it's a place still in Ireland that you can go and seek restitution of your hemorrhoids. See? I'm not going to talk about surgical treatments because I don't do those, but my understanding is, these are the 3 standard treatments. Excisional hemorrhoidectomy is really reserved for the most extreme cases and probably has the most difficult recovery, but Doppler-guided hemorrhoid artery ligation, which really addresses the blood flow into the hemorrhoidal tissue, and stapled hemorrhoidpexy are both commonly done. The special situations are, one, I talked briefly about the thrombosed external hemorrhoids. There are situations where we might get our colorectal surgery colleagues involved if they're having recurrent thromboses on the external hemorrhoids where they're getting a blood clot there, and they can excise the blood clot. Pregnancy, we frequently get referrals from pregnant patients. For obvious reasons, we don't want to instrument them more than needed, and so I'm often suggesting simple therapies such as sit-spats in order to decrease the sphincter spasm, fiber, and focusing on the bowel movements. Immunocompromised patients are also a challenging one because now your differential, when people complain about anterectal disorders, could include a pelvic abscess. But moreover, especially if they're neutropenic, instrumentation in this area carries risk. And let's say if we place a rubber band or do coagulation, you can induce ulceration there, which could predispose them to having an abscess down the line. In cirrhosis, you have excessive portal flow, so this is also a higher risk group. And I forgot to list inflammatory bowel disease, where you can induce, because you intentionally through treatment of the hemorrhoids cause ulceration, you can induce a flare, which can be quite debilitating. One of my patients with Crohn's didn't believe me and found a doctor who was willing to treat her hemorrhoids, and she was in and out of the hospital for months with a recurrent abscess. And that concludes my talk.
Great. So last but not least, our final speaker for this session is Dr. Andrea Portocarrero. Dr. Portocarrero obtained her medical degree from Cayetano Heredia University in Lima, Peru. She moved to Ohio for a residency training and gastroenterology fellowship at the University of Cincinnati Medical Center. And lucky for us, she joined our division last fall as a clinical educator. She has an interest in general gastroenterology and pelvic floor and anorectal disorders. And the title of her talk today is Diverticulosis, Little Pockets, Big Problems.
Thank you. Thank you for this opportunity. I'm very happy to be here and to talk about diverticulosis. So this is the agenda. I will start with epidemiology. We'll go through the different definitions, and I will then mainly focus on the management of acute and complicated diverticulitis, and then we'll go through diet, lifestyle, and other risk factors. So starting with epidemiology, diverticulosis is very common. About 60% of patients would develop diverticulosis by the age of 60, but only 5% or fewer would develop diverticulitis. And we know that two features dominate the epidemiologic profile of diverticulosis, and these are age and geography. The prevalence clearly increases with age, and it ranges from less than 10% in patients younger than 40 years old, and it can be up to 60 to 70% in patients that are older than 60. And regarding geographic association, diverticulosis has been considered a disease of the Western civilization with the highest prevalence rates in industrialized countries like the USA, Europe, and Australia. And we can see that in Western countries, 90% of patients have diverticulosis on the left side, whereas individuals from Asian countries tend to have about an 80% right-sided predominance. It is crucial to note that the patients that develop diverticulitis, only 12% or less will have a complicated course, so most of the diverticulitis is uncomplicated. And it's also important to note that the clinical impact is remarkable, since annually in the US, there are more than 1.9 million outpatient visits and over 200,000 inpatient admissions for diverticulitis at a cost of $5.5 billion. So diverticulosis may be asymptomatic or symptomatic. Diverticular disease is defined as a clinical significant diverticulosis due to either diverticulitis, diverticular bleed, symptomatic uncomplicated diverticular disease, or segmental colitis associated with diverticulosis or SCAD. And diverticulitis, as we said, may be acute or chronic, can be complicated and uncomplicated. Most of the cases can be complicated by abscess, fistula, obstruction, or perforation. And a little bit about SCAD. So SCAD, or diverticular colitis, is characterized by inflammation in the interdiverticular mucosa without involvement of the diverticular orifice itself. And SCAD, it's a relatively new term, mostly used in Europe. That is characterized by persistent abdominal pain that is attributed to the diverticula, but in the absence of overt inflammation. And this is thought to be due to visceral hypersensitivity related to diverticulosis, and it is unclear whether SAD it really represents a disease of its own, or it may be the coexistence of IBS and diverticulosis. There is another term which is a smoldering diverticulitis, which is a milder, less severe presentation of recurrent diverticulitis with persistent low-level inflammation, but without overt colitis. This is a figure extracted from the AGA Clinical Practice Updates of 2021. And this update goes through different evidence-based recommendations, but also expert opinion regarding common practice. So to start, a CT should be considered for the diagnosis of patients without a prior imaging confirming diagnosis, and also should be considered in patients with a severe presentation to evaluate for potential complications. This guideline also points out that the use of antibiotics should be selective rather than mandatory in patients with uncomplicated disease. And this is because over the past decade, previous dogmas regarding the use of antibiotics to treat uncomplicated diverticulitis have been challenged. So diving a little bit deeper into antibiotics. This is a Swedish study called the AVOT trial, which is the largest randomized controlled trial that evaluated whether antibiotics were necessary for the treatment of uncomplicated diverticulitis. And it was performed in 10 centers in Europe, including over 600 patients that were randomized to treatment with or without antibiotics and were followed up for 12 months. There were no differences in clinical signs during hospitalization, including abdominal pain, temperature, or abdominal tenderness on exam, and there were also no difference in development of complications like perforation, length of stay, or recurrence that require readmission. There was a follow-up study that was published later that followed patients for 11 years, and it still showed that there were no differences in clinical outcomes. There's another randomized controlled trial from Europe, this one from the Netherlands, where over 500 patients with proven left-sided uncomplicated diverticulitis were randomized to either amoxicillin versus observation. And on the left, we can see that there is, here's the percentage of no recovery, and on the right, there is the pain score. And there was really no difference between these outcomes during a 6-month follow-up. They did another study following the same group of the Diabolo study with a longer follow-up period of 24 months. And still, there was no difference in recurrent diverticulitis, complicated diverticulitis, or sigma resection among the two groups. So in regards to the approach to antibiotic therapy, this is a nation database cohort that compared the use of 2 antibiotics, amoxicillin versus Cipro and, fluoroquinolones. And it found that there were no differences in 1-year readmission rates, urgent surgery, or 3-year elective surgery risk, but there were differences in 1-year C. diff infection, which was higher for the group that used metronidazole with fluoroquinolones. So below here is just a chart with the different antibiotic options for outpatient versus outpatient, mainly for reference. So it is important to note that the antibiotic recommendations for diverticulitis are based on studies for intra-abdominal infections, but there are really no studies that particularly evaluate antibiotics and diverticulitis itself. So the approach to uncomplicated diverticulitis in terms of patient risk. This is very straightforward. So in one side, we have low-risk patients, which are the ones that have no significant comorbidities, that tolerate PO intake, that are able to obtain antibiotics if needed, and that are able to have adequate follow-up. So in those patients, we can consider whether or not we use antibiotics, compared to a high-risk patient that is, for example, someone with immunosuppression, has significant comorbidities, an ASA of 3 or 4, has a high CRP or elevated leukocytosis, signs of sepsis, or a longer segment of inflammation on a CT, and has no reliable follow-up. So in these patients, even if they have an uncomplicated diverticulitis, then we would recommend to use antibiotics. So this is a practical approach in low-risk patients. So how do we start? We'll obtain a CT scan to evaluate if it's the first episode or if it's a severe presentation. We will consider the selective use of antibiotics, and we'll prefer to use amoxicillin for 4 to 7 days. We will consider a clear liquid diet for 1 to 2 days in advance as tolerated, mainly for patient comfort, but there's really not a lot of data to support this recommendation. And we can use Tylenol for pain. We would avoid narcotics and NSAIDs, as we will see following up, and it's important to have a close follow-up. In contrast, if we had a patient with that was immunocompromised, had a lot of comorbidities, those are more likely to present with a severe or complicated disease. So for these patients, there will be a low threshold for, of course, obtaining a CT, giving antibiotics, and also consulting with a colorectal surgeon. Briefly on diet, during the acute phase, It is advised, and excuse me, the AGA practice update guidelines suggest to use 1 to 2 days of clear liquid diet during just the acute phase, but there is really no evidence that bowel rest has a positive impact in the healing process of diverticulitis. And this has been previously analyzed in a systematic review in 2018, where liberalized diet and restricted diet were really equal in terms of recovery. So there's really no high quality research, but it's still recommended for patients' comfort because sometimes they like it and they may feel better. So when do we perform a colonoscopy? It's even after a CT that these patients often have, a malignancy can be misdiagnosed as diverticulitis. So it is important to know what is the risk of colon cancer following an episode of acute diverticulitis. So in a systematic review and meta-analysis of 31 studies and over 500,000 patients, it showed that about 1.5 of patients with uncomplicated diverticulitis will have a final diagnosis of colon cancer, compared to about 8% of patients with complicated diverticulitis that will end up having a diagnosis of colon cancer on follow-up. So based on this evidence, a colonoscopy is recommended after the first episode or after an episode of complicated diverticulitis, and it's also recommended after the first episode of uncomplicated diverticulitis. And this could be deferred if a recent high-quality colonoscopy has been performed within 1 year. And of note, all guidelines recommend colonoscopy after complicated diverticulitis. The data is less clear regarding recommendations after uncomplicated episodes, but the AGA still recommends it. And the recommendation for colonoscopy is after an incident diverticulitis, so there's really no need to repeat colonoscopy after every episode. So reducing the risk of recurrence. This is very important for patient education. So the risk factors for diverticulitis fall into broad categories of diet, lifestyle, medications, and also genetics. So a high-quality diet, high in fiber, fresh fruits and vegetables, whole grains, legumes, and low in red meat and sweets, and a vegetarian diet are associated with a decreased risk of incident diverticulitis. A fiber supplement can be used, but is not a replacement for high-quality diet. Also important to note that nut, corn, and popcorn consumption is not associated with an increased risk of diverticulitis. And similarly, consuming fruits with small seeds, strawberries, is not associated with risk. In terms of lifestyle, physical activity, especially vigorous activity, decreases risk. And obesity, particularly central obesity, as we can see, weight gain and smoking are also risk factors. And alcoholism, but not necessarily alcohol consumption by itself, increases the risk as well. And in terms of medications, regular use of NSAIDs increases the risk of diverticulitis, and the risk is greater in non-aspirin NSAIDs than for aspirin. And also, steroids and opioids are associated with diverticulitis and also with perforation. And it's also important to be careful with hormonal replacement therapy and menopause, which is also associated with increased risk. So what can we do to prevent recurrent diverticulitis? Unfortunately, there is no particular therapy to offer. In a meta-analysis of 7 randomized controlled trials, there was no benefit when comparing mesalamine with control for prevention of recurrent diverticulitis, and there is insufficient evidence to support the use of any probiotics or cycline rifaximin to prevent diverticulitis. And this is, in fact, one of the strongest recommendations from the AGA to recommend against the use of mesalamine. All right, so when do we consider surgery for the treatment of recurrent diverticulitis? So in the past, elective resection was advised after the second episode of recurrent diverticulitis due to concern for high risk of complications. However, this is no longer the recommendations since the complication risk actually decreases with further episodes. So we would recommend surgery when a patient has frequent or severe attacks, when has a significant impact on their quality of life, when, for example, has smoldering diverticulitis, so chronic, non-resolving, inflammation. And it is important to know that this decision should be personalized and discussed along with the patient, the surgeons, the gastroenterologists, and oftentimes the primary care as well. And so when do we avoid surgery? We should avoid making the decision solely on the number of episodes. We should probably avoid doing surgery when these episodes are easily resolving with treatment, they are infrequent, or when patients have functional symptoms without evidence of inflammation, and also when patients have diverticulitis in multiple locations. It is important to note that surgery really would address the diverticulitis, but there's still a small risk of recurrence despite surgery. So it's important to have all of those conversations with patients. So for closing remarks, colonic diverticulosis is common in the Western world, and the incidence is increasing. Antibiotic treatment can be used selectively rather than routinely in immunocompetent patients with mild and complicated diverticulitis. To reduce the risk of recurrence, patients should consume a high-quality diet, achieve or maintain a normal BMI, and be routinely physically active and not smoke. And patients should avoid regular use of NSAIDs more than 2 times per week, except aspirin prescribed for secondary prevention of cardiovascular disease. Previous recommendations to consider elective surgery after 2 attacks have evolved into an individualized approach. And to this date, most of the recommendations are based on low to moderate quality of evidence, and further research is still needed. Thank you.
All right, so the first question will go to Dr. Portocarrero. Is there a role for, what's the role of the microbiome in diverticulitis, and has anyone studied FMT as a prevention?
I don't know if there's anyone else in this group that would like to address that in terms of the microbiome, but I am not aware of any studies particularly evaluating diverticulitis, but it would be interesting to know if someone else knows that.
Okay, and the next question will be Dr. Spencer. There's a couple questions about those stool microbiome tests patients bring in. One of the questions is, what do you think about them? The other is, where are we with regards to using stool tests to understand the ability of the microbiota to break down fiber?
So in terms of stool testing, I think there are no clinically validated stool tests that can inform our practice. Patients do come in with them quite frequently. And the issue is more of a broad issue in terms of the scientific understanding of the microbiome. Due to very high inter-individual variability, our understanding of what constitutes a healthy microbiome is surprisingly foggy. And I think that really limits our current understanding of testing. I mentioned in terms of a dysbiosis, the balance between the good and the bad. Everyone's good bugs tend to be very different, but we do have a fairly clear understanding of bad bugs, and these are the Enterobacteriaceae. So these are like the E. coli, the Klebsiella, Enterococci. If a patient brings in a stool test and they report very high levels of kind of the Enterobacteriaceae family, that does indicate that something may be dysbiosis is likely, but we're still kind of early days, no clinically validated tests. And in terms of fiber, on the research side, we're actively working on developing those, but there are no current fiber degrading tests available.
Thank you. The next question will be for Dr. Gottfried. Should everyone just get a G-POEM up front for gastroparesis diagnosis? It has a good safety profile, data is encouraging. So far, no FDA-approved medications besides Reglan. What is the downside of just pushing this to the front of the algorithm?
That's a great question. I think that the data so far have been very good with G-POEM, well tolerated. But I think it's not a good idea just to send everybody for G-POEM. First of all, it's an irreversible procedure. There are complications. Patients do need, in our center, patients are admitted overnight for observation. And I think a stepwise approach is still important. And there's logistical considerations. Insurance companies are still very difficult to get GPOM approved for gastroparesis. So I think as the data continues to accrue in terms of efficacy and safety, insurance landscape might change, but we're not there yet. But in my personal practice, what I'll do is I'll try to select for patients that are likely to benefit by doing a trial of pyloric Botox injection and see if they improve. Another tool at our disposal is to examine the pylorus when we do endoscopy, see if it's very narrow, if there's resistance to intubation. If you have access to EndoFlip, you can measure the sensibility of the pylorus. So these are things that we're trying to incorporate in our practice and our evaluations.
Great, thank you. Okay, so for Dr. Singh, how do you manage hemorrhoids in those with rectal disease like IBD, radiation proctitis?
It's the most challenging group I find is ulcer proctitis because their symptoms will overlap and sometimes you don't know without doing a sigmoidoscopy. And because hemorrhoids are common and you can have both IBD and hemorrhoids. Generally, I will not offer any sort of procedural intervention, but thankfully, at least for the proctitis patients, I can use a steroid suppository and take two birds out with one stone. Otherwise, for the most part, I really focus on conservative management with focusing on the fiber and the bowel movements because your risk with any sort of intervention is much higher, as I referenced earlier.
And there's another question, I guess, regarding hemorrhoids and microbiome health. And are gummy fiber supplements acceptable?
From my perspective, in terms of fiber, it really focuses on helping with bowel movements. And psyllium husk is the one that all the medical studies are done on. I'm aware of 1 or 2 studies on wheat bran fiber and with mixed results. And if I remember correctly, the wheat bran group took much longer to actually induce effect. They missed their primary endpoint. Now, but my gut microbiota standpoint, I have no idea if there's a differential effect. And so I always, I tell my patients, I'm an academician, I'm going to recommend psyllium husk over anything else because that's what we have studies for.
Okay, there was a question. Oh, sorry, Sean, did you have anything to add?
Yeah, I can comment quickly on that. I can reiterate that psyllium husk is great. Psyllium husk is excellent for many reasons, and one of them is that we typically, in our traditional view of fiber, we put it in buckets of soluble and insoluble. But I think also layered on top of that, we need to think about fermentable and non-fermentable. Psyllium is very poorly fermented, and it's insoluble. Therefore, it is really good at passing through the entire length of the GI tract, drawing water in, and really it's weakly fermentable and does have some microbiome promoting capacity. But I think the question specifically referenced the gummies, and the fiber gummies tend to have soluble fiber that is highly fermentable and will be fermented most likely in the small intestine or very proximal large intestine. None of that will reach the rectum. So I think in this case, yes, psyllium is the clear winner for hemorrhoids.
Great. There was a question about whether there are any studies on slowing progression of neurodegenerative diseases with fecal transplants to alter the microbiota. And I texted Dr. Becker, and he says that there are several small studies that have been done that show some promise, but there really isn't, the data is very scant. And there is a need for more randomized clinical trials in the subject to determine whether that will be helpful. Okay, question for Dr. Portocarrero. Could you comment on any need to avoid foods such as nuts, seeds, etc.? Is this just a myth?
So yeah, we briefly went through that in my talk, and there's really no evidence that shows that avoidance or of nut, corn, popcorn, or small seeds is associated with an increased risk of diverticulitis. And actually, there is an association with a decreased risk of incident diverticulitis. So patients often ask these questions, and some patients feel like they don't do well when they eat popcorn, nuts, or seeds. And in those patients, I think it's important to listen to what their symptoms are, and if they are saying and they're swearing that these are triggering their symptoms, then I just explain what the evidence shows, but I do not dismiss their concerns.
Great. So, Dr. Spencer, or anybody in the panel, do you recommend probiotic when a patient's taking an antibiotic? And if not, what do you recommend?
I did not have time to mention in my presentation, but there's a very high quality randomized control trial in which they looked at microbiome reconstitution after antibiotics. And they randomized people either to placebo, a probiotic, or an auto FMT, so basically just giving the pre-antibiotic stool back. And what it showed very clearly was that taking a probiotic with or after an antibiotic inhibits microbiome reconstitution pretty potently, actually, and potentially permanently. So I think patients that are taking antibiotics, I think there is data to support that probiotics may be helpful for the symptoms of loose stool while on it, but none of those trials looked at outcome of microbiome long-term outcomes. So I think it's important to understand that the evidence is for symptomatic management of the diarrhea associated with antibiotic use, and that there is increasing evidence that probiotics in the setting of antibiotics could be harmful to the microbiome. And again, it's not necessarily a patient-centered outcome. It's microbiome. And I think it's important to, when counseling patients, to understand what the data are in terms of patient-centered outcomes and then theoretical risks in terms of microbiome outcomes. But I would say that the data is suggesting now that there are significant risks to taking a probiotic after antibiotics.
Great, thank you.
Can I just add a comment to that? So what I end up doing is I advise my patients that they could do prebiotics or fermented foods, which have probiotics in them. It's just not the vast amounts that come in these prepackaged capsules.
Thank you. Dr. Gottfried, what can we tell patients to expect about recovery from post-viral gastroparesis?
From post?
Viral gastroparesis.
Post-viral gastroparesis falls under the realm of post-infectious gastroparesis. There's not great data. I think most of it is anecdotal. But if you ask me or other specialists in the field, the consensus we have is that it is a better outcome, which applies, I guess, to a lot of our functional GI disorders, in terms that a lot of post-infectious motility problems do tend to wane with time. And so I'll advise my patients that usually it's the inflammation that comes associated with the infection, which has led to either the dysmotility or the hypersensitivity. And I've had patients that have their symptoms disappear in a year, sometimes 6 months, sometimes 2 years. But I try to be more optimistic with patients that have post-infectious gastroparesis.
Okay, another question on gastroparesis is, what is the mechanism of nausea and vomiting with frequent use of marijuana? Gastroparesis or central or both?
That question has a lot of layers to it. Practically speaking, I do not advise or recommend marijuana to my gastroparesis patients. I think we have a really good, although we don't have a cure for gastroparesis, we do have a lot of antiemetics in our pharmacologic repertoire. So I always try to go down the line of different antiemetics before I support them to be on marijuana. To my knowledge, cannabinoids do not slow the stomach. So, yeah, it's more about the antiemetic effect that they have in the patients. We're all aware of cannabis hyperemesis syndrome in patients that take marijuana or marijuana products on a frequent basis. And I always advise my patients about that risk if they want to continue them. But as you might know, some of our patients with gastroparesis are really, just trying to hang in there, and they'll take anything to be able to eat and not keep losing weight because of the severity of their symptoms. So mechanistically speaking, to that question, I don't think we really know. Nausea can be centrally mediated, it can be peripherally mediated, so and I don't think we have the right tools to diagnose those differences. Sometimes the response to the antiemetic is helpful in determining nausea causes, and sometimes in severe cases where nausea is just a predominant symptom that's not related to food per se, I will have them undergo a neurologic evaluation for vestibular problems.
Okay, and one last question. Are we not helping active IBD patients by restricting fiber as probiotic intake? I guess in the acute setting, when patients are being treated for IBD, we often put them on a low residue diet. Is that helping or hindering?
Yeah, I think it's important, and this has relevance in gastroparesis too, in terms of low residue diets and low fiber diet. I think what we need to be clear about is that the world of fiber is very diverse. There are many kinds, and there are now diets, especially in gastroparesis, low particle size diets or giving soluble fiber that can be helpful. And I think, as I stressed in the last slide, when thinking about fiber and IBD, it's really important to assess the degrading capacity of the microbiome, because in the absence of a microbiome, fiber does not benefit us at all, and it can be harmful if fermented inappropriately in IBD patients. So I think I would say we don't have enough evidence in IBD yet, but there are a lot of people with this on the front of their mind enrolling very high-quality clinical trials now, and I think that we will have high-quality data around this topic in the near future, especially as we get more microbial therapeutics online. I think expanding that dietary availability and options in GI disease states will actually be one of the best properties of microbial therapeutics.
Great, thank you. So we do have time for a few more questions, so let's. Any data on vitamin D supplements and reduced recurrence of diverticulitis?
There is some evidence. I don't recall exactly what studies, but there is some evidence that it reduces. And I am not exactly aware of the details, but there is.
Okay, great. Dr. Gottfried, can we order spirulina breath tests through Epic? I guess that's a practical question.
That is a practical, logistical question. I have not done it, so I don't know. At Stanford, we have the gastric 4-hour scintigraphy with a solid meal, and so that's what I use. So I'm not sure. Does anybody else in the group know?
I don't believe so. Okay, so that brings our session to a conclusion. Thank you so much for your attendance and for your wonderful, insightful questions. I'd like to remind you that breakfast is still available, and please check out our exhibitors next door. And come back at 10:10 for our IBD session, which is bound to be excellent. Thanks again.